And now we're going to turn our attention to our clinical speaker today. And Dr. Shankar Iyer received his dental degree and specialty training in prosthodontics from NYU. Currently, he has faculty appointments in the Department of Perio and Pros at Rutgers School of Dental Medicine, and he's the co-director of their AAID Maxi course. He's also co-director of our AAID Maxi course here in Southern California, and he has trained hundreds, could be even thousands at this point, of dentists around the world, and he's lectured in over 20 countries. He's got a great topic today. He's going to be talking about sinus grafting, the lateral approach, and it is an honor to turn this over to Dr. Shankar Iyer. It's all yours, Shankar.
Great. Thank you, Dr. Park, for having me over. It's always a pleasure to be on this panel. Great tips from Gary, Mary, David, and Roger. It's always a stimulating concept to have these new topics brought in. And I don't know how you find all these new ideas, but each time there's always something new to learn from these experts. So the topic I'm going to be presenting today is very dear to me because of the fact that I strongly believe that we need to go back to some basic principles of bone grafting. A lot of focus is now being placed upon graftless solutions as if grafting is something bad. So we need to look at the benefits of going back to some of those traditional grafting concepts to help patients combat edentulosum. If you look at the skulls of the fontanelles, generally, when you look at these spaces, the fontanelles have not fused and the sinuses have not really grown. So without the alveolar process, the sinus doesn't grow. And the purpose of the sinuses generally are to moderate the temperature of the air we breathe, because if it's very, very cold, when you breathe in, we need a space for it to temper. If you're in the Arctic, you have minus 10 degrees. And then if you have these air go in, it could freeze your lungs. Or in the desert, you need some mechanism in the body to moderate the temperature. And then we also feel that the skull weight could be reduced because of the sinuses. And then the tone of the voice. When you get a cold, the voice changes, the tone of the voice changes. So it's important to have voice modulation from the sinus. So that's a sacred space we need to respect. As long as the teeth are present, the sinuses are kept away from the alveolar process. There's something about the teeth and the way the teeth are positioned. It kind of resists the expansion of the sinus because there is an intrasinus pressure due to breathing that wants to keep expanding. And you can see that the rate of expansion is going to be proportional to the rate of extractions that we are going to perform, and it's never always even. And you can almost predict the time of the extraction process. The teeth that were extracted first, in this case, happens to be the first molar, and then it progresses from there on. So from the shape of the resorption, you can almost predict how the teeth were extracted and the chronological sequence of events that took place. Here is the pneumatized sinuses, borderline combination syndrome. And when it gets to the point, we are in a quandary. How should we rehabilitate the maxilla, especially when the sinus have pneumatized tremendously to a point where the entire alveolar process has disappeared? Well, we find today we are trying to avoid doing grafts, and people are trying to get into the pterygoids and then also go into zygoma, but then the platform of the zygoma is going to cause oroantral fistula in cases like this. You need a minimum of about 3 to 4 millimeters of the crestal bone for the zygomas to work. So in an eggshell sinus, it's going to be quite a challenge to be able to rehabilitate these maxillary arches. So this is the reason why we need to get back into the process of grafting the sinus and increasing the bone volume vertically. Some anatomy. This is the frontal sinus, ethmoidal sinus, and we are now entering the territory of the ENT world, and that's the superior concha, the septal cartilage, middle concha, or the terminal process, which leads to the ostium, which is part of the inferior meatus, and that's about 2/3 the height of the maxillary sinus. That's the inferior concha, where the drainage of the nasolacrimal duct takes place. Here is the maxilla with the four processes, the zygomatic, frontal, alveolar, and palatine. And this is the ostium that we just spoke about. And it's a pyramidal shaped cavity that has about five walls, the medial wall, the superior wall, which is the floor of the orbit, the anterolateral wall. Then there is the floor with the palate, and then the posterior wall. This is the dissection specimen where you can see the middle meatus. This is the path that the ENT surgeons will go through with the endoscopy to be able to see the sinus and also perform the intranasal antrostomy, and also many of the FRIS procedures are performed through this spaces. The sagittal section gives us a complete overview of the distribution of the sinus and the intercommunication. So when we do these crestal lifts and lateral lifts, we need to have a good understanding of how the anatomy is actually positioned so that our procedures can be done safely. So this is the nasolacrimal duct. I'm dedicating this presentation to one of my mentors, Dr. Hill Tatum. This was years ago when he had come to the office, and I've taken several courses with him, and it's really a pleasure to see him operate. This is from his extract from 1974. So he's been working at it since 1974. He just turned 90. He's going to be 91 very soon. And this was at 2001 when he says all these techniques were there since 71. And we're trying to get these anatomical areas accessed in a way that it could be safe. So he used autogenous bone for the first graft, and then they also used inflatable catheter in 1980. So he developed many of the instruments that I'll be showing you, and we owe it to Dr. Tatum for being able to get into the sinus areas to help our patients combat partial edentulosum. This is a technique that he generally uses to be able to do the lateral approach. As you can see, the approach is very, very controlled, and it has a direct access. When we do find some obstruction, these are some of the contraindications to perform lateral approach lifts. When the sinuses are cloudy, you could get an ENT clearance, but we need to know the underlying pathology because the grafts should not irritate the sinus and cause sinusitis. These are the nasal polyps that have been retrieved by the ENT surgeons to kind of remove all of the thickening of the mucosa. And when we take our radiographs, a periapical film, it's almost imperative that we analyze all of the teeth before extract. So here is a case where you can see a thin periapical radiolucency. Now, it was not the standard of care to do a CT scan before extraction. We generally rely upon a panoramic film or a periapical film, and we won't think of taking a CBCT before extraction. This patient's sinus is almost filled up to 100% from an odontogenic origin. So there is now a periapical lesion that's actually causing inflammation and sinusitis to a point where the patient was not able to breathe properly, and there was drainage. So if we had extracted the tooth without having this understanding of the communication, we would probably end up in an oroantral fistula. And it's also very dangerous to do a socket grafting in this case without really having a clear picture of what we are going to be dealing with. So extraction and socket grafting should generally be preceded by a complete analysis of the diagnosis through a CBCT to make sure that we don't dump a lot of these grafts into the sinus in the presence of this kind of a obstruction. So it takes about 4 months for the sinus to resolve after we do this carefully. And then once we have the sinus resolved, we can then start to plan our crestal lifts or lateral lifts, whichever is deemed for that particular situation. So here's the case from 2000. My first sinus lift was performed in 1995. And this is from 2000 when the patient came in with a chief complaint of unable to chew on the maxilla, and patient also had a dentulous situation in the mandible as well. So here's the case with a full mouth series. You can see most of the teeth are kind of hopeless. If you really look at the prognosis of some of these natural teeth, I'm sure many will agree that the maxillary teeth are sort of hopeless. However, if you look at it carefully, 6, 8, 9, 10, 11 are sort of, maintainable. 10 probably needs to be extracted. 2 also would probably be extracted, and so is 12, 13, and 15. So if you look at a panoramic film, you can see I'm using the analog film. I didn't have the digital pan till 2004. So you can appreciate the fact that many of these teeth are kind of hopeless. So we need to extract the teeth. So what would be an ideal plan to give the patient a fixed maxillary reconstruction? Patient's not keen on having a partial. So if this patient walked into our office today, and if you looked at some of the treatment options, you may look at CBCTs and you may look at CT scan. This is actually a CT scan that we used to take in the early part of 2000 and late 1990s. I'm sure Dr. Hochberg would agree with me that there weren't too many softwares available at the time. We relied heavily on Columbia Scientific, and something called as Dentascan was popular at that time. So this is a medical CT, and this is the cross-sectional view from the Dentascan showing that they can mucosa, the epithelial lining, as well as the atrophic posterior maxilla. So given this clinical scenario, what would be the options? Today, I think most of you would agree that it will end up in a graftless solution, where we may think of placing 4 implants like this, and then do an immediate placement and get on with an immediate load. So this sense of urgency has kind of changed the way we do our treatment plans. And that's something that we need to rethink and look at what other options exist. If we are able to maintain the anterior teeth and just focus on the posteriors, we could do a bilateral sinus lifts, and then place implants in the posterior maxilla and try and maintain the anterior teeth. That may look far-fetched. This is going back in 2000, right? We probably will not be giving that much attributes to natural teeth. So let's look at the sequence of how we are going to be doing this. I don't know why it. Sorry. So this is the approach made with a round burr. Number 10 round burr was what was recommended by Dr. Tatum. So he likes the large round burr. And we made a window. And if you encountered a septum, we will probably make 2 separate windows and try and do our lifts that way. So this would be a classic elevation. It took about an hour and a half to do each sinus lift. And then we grafted the site with a mixture of xenograft and allografts. We really didn't have much studies until Steve Wallace published papers on histology for post-sinus grafting procedures. So it was arbitrarily assumed that xenografts are very good because of the opacity it produces, and the allografts has biological capabilities of turnover. So post-grafting, we waited for about 5-6 months and then placed these implants, and I did this restoration in FP1 way back in 2000. So this was the post-op of the case immediately after we completed. So this is a 20-year follow-up of the case. And I wish to bring to your notice that these are all external hex implants. At that time, we were using a lot of Branamac and Branamac clones from 3i. These are all external hex. And this is a 20-year follow-up. And you can now see that the reconstruction that I did 24 years ago is still the same way it is today. So there's something to be said about bone stability, occlusion, reconstruction. The way we are handling canine guidance, you can see that we didn't extract 6 and 11, which was the saving grace for this case, where I was able to provide a canine protected occlusal scheme. Tooth number 7 is an implant. You can see mild recession there, but otherwise the reconstruction seemed to have held up for the past 24 years. So there is something to be said about the stability of our grafts and long-term outcomes with our implants. So now, is that only limited to a full quadrant. What about a single tooth? So here is a pneumatized sinus where you have the expansion of the sinus all the way to the crest of the ridge. So it's very hard to do a lateral approach in a controlled fashion, especially when there's a undulation in the floor of the sinus. So this requires a lateral approach so that we can lift the entire membrane from the lateral wall and take it up so that we can bring it up close slowly and be able to fill this entire floor of the sinus. So this would be one way to handle a partially dental situation with a single tooth. So we're using reamers in this case to gain access to the window. And then this is going to be done as a two-stage. We shall lift the membrane, place the graft, and then you can see the fill. So this will allow us to be able to place a decent sized implant to be able to provide a single tooth restoration. It may look a little invasive in terms of the approach. Why not do a 3-unit bridge? But tooth number 13 is a root canal treated tooth, and the prognosis of 15 is also questionable in terms of its restoration. So this is where we probably will have to decide upon whether we want to go with a single tooth implant or a 3-unit bridge. So here's the reason why a single tooth implant was preferred over a 3-unit bridge. So here, if I had about 5 millimeters of crestal height of bone, this will lend itself for simultaneous lateral lift as well as immediate placement. So the approach is made from the lateral window. You can see the floor of the sinus has about 5 millimeters of residual volume of bone. So the approach is made with a reamer in this case, where we will remove the portion of the window, do our lift, place the implant at the same time, and also graft. So this would be all done together, and then the window is placed back so we can have continuity of the osseous surface. And then a PRF membrane is placed over it, and this would be a one-stage approach. You can see the fill, and this becomes very predictable because this is something that would be very difficult to do through a crestal approach in a manner that's going to be uniform. What about full arch cases where we require aesthetic and functional rehab? This patient presented in 2004 with a deep bite and a failing maxillary anterior bridge. The sinuses are pneumatized, as you can see, and the patient is desirous of a fixed maxillary reconstruction. So the patient was given multiple options. So the decision tree, which I follow, is based on a set of patient factors, which depends upon the age of the patient, younger the patient, over-engineer, desires of the patient, if the patient wouldn't mind having an interim, or the patient wants to have something right away. Having the partial for all these years, I don't think she's in a hurry to have these teeth restored all at once. Opposing occlusion is natural dentition, so we may have to think about over-engineering. What about parafunctional habits, finances, interim requirements? All these factors we have no control over, but we do have control over the available bone. If it's deficient, we can augment. Biomechanical factors. Do I have cantilevers, or can I do a sort of a splinted type of restoration, or can I do freestanding? Do I have the skill to be able to restore this case, start to finish? What about the prosthetic consideration? Is it going to be an FP1, FP2, or FP3? And eventually, how demanding the patient is in terms of aesthetics. They all will play a role in how you arrive at a treatment plan. So if we decided to go the all-on-4 route or a grafted solution, the minimum reduction is going to be about 5 to 6 millimeters of the alveolus. If we don't do this reduction, you'll end up with a ridge lap and fracture of the prosthesis because the prosthetic space is inadequate. And if we do get the space and we do have a acrylic hybrid, and if the opposing occlusion is going to be a natural dentition with these cantilevers, you may end up fracturing the hybrid prosthesis which has the acrylic overlay. So these are some of the biomechanical factors we need to bear in mind. And if the patient has parafunction, all the more reason to be able to over-engineer the case. So it was decided that we would go with a bilateral sinus lift. And again, I'm going to be using a mixture of a round diamond as well as piezo. Piezos were introduced in 2004, 2005. The Italian company came to the US, and we were using this to be able to gain access to the lateral window. So the shift took place from a round diamond to piezo. Uh, Different options of leaving the window, whether we keep the bone or peel off, it's a personal choice. I like to peel it off. And there you can see what Dr. Tatum has designed and what some other companies have tried to copy. We need to have a wide base, and the instrument needs to be quite sharp. And you can see the triangle position and the design of this instrument, because the sinus is not like an eggshell. The sinus has multiple undulations and it's not a uniform flow. So you must be able to navigate the entire sinus lining without any tears. I need to make sure that you go to the medial wall and lift up the entire membrane to the medial wall. So these instruments, as you can see, help us in being able to detach the membrane. Basically, Dr. Shanama says it's not really a membrane because it's only an epithelium. So whatever you want to call it, it is a lining that needs to be elevated so we can preserve that more from a perspective of containment of the graft. So in the event that you suspect any kind of perforation, we would place a membrane with memory built in. We won't be using membranes without any kind of memory because that will collapse. So I like to personally use membranes that have memory that can hold the membrane up without collapsing. So here again, the mixture is used for the lateral lift, and the same thing on the right side as well as the left side. So here we have the um, augmentation on the right and left. Now we have to worry about the premaxilla. And there I'm going to do a bilateral chin block to be able to augment the anterior maxilla. Why? Because the case in question here is an FP1. We want to preserve as much vertical height of bone as possible. So after placement, this is Atlantis abutments in 2004. They used to send us an STL file. We didn't know what we were looking at, but at least we could critique the fact that the abutments are lining up right under the prosthesis. So we sent out these wax ups, and the Atlantis company, they sent us these designs, and we used to modify the abutments to make sure that they contained within the confines of the restoration. And these were tried in for a cement retained restoration. You can see the robust abutments with parallel walls. We could also ask them to put grooves. And now this has become the industry standard in being able to design these custom abutments. I was a fan of PFM restorations in the past, so I still do a lot of PFMs. Here is the baseboard transfer, do a pickup impression, and the final restoration is an FP1 restoration. It's very hard these days to find these embrasures, and these embrasures are the ones that help us preserve the health of the permucosal areas. So you don't see very large prostheses today that will have a lot of platform to be able to have the bulk. So this is classic crown bridge restoration for implant reconstruction. Now, do I really need that many implants in an arch? Well, at that time, the concept was over-engineering. You always placed more implants than you need. But what it did for me in this particular situation, especially patient being young, she was 48 when she saw me. Now she is 68. This is a post-op review, the protrusive relationship, right lateral, left lateral. So we are still maintaining a mutually protected occlusal scheme. So this is a 15-year follow-up of an FP1 restoration, and that's an 18-year follow-up of the same prosthesis. Not a single crown has been restored or changed. It's been the same for the past 20 years. And if she comes for her maintenance, and God bless her, no other changes take place in her health, I could probably keep this on for another 20 years. This is the patient's feedback.
So here with gives you more access for the
surgical
anterolateral
view.
wall. I'm going to give this elevator
This is the historical
to
review
Miss Anjali
of
here.
how we used to do our lateral approach with round burrs. So these round burrs they used at low speed, parallel to the wall, and then
You see how it's done?
we used it in a paintbrush motion, and we connected it, and then we'll also follow this up with the piezo. So this is the first use of the piezo, dating back to 2005 when we used to do our courses. And these piezos were mainly made in Italy, and they hadn't come to US at that point. So this is now in 2005. I'm using the piezo in place of the round diamond. And I was very skeptical at that point whether the piezo will puncture or not. And you can see the contiguous osteotomy that's being made to detach that window. So we use instruments that will help us. You can see that instrument will point towards us. And as we approach the anterior wall, we want to maintain contact of the instrument with the bone at all times. So this is a carefully performed procedure so we don't tear. And that's the reason why the instruments are triangle to be able to circumvent all the bends. And that's the floor. So you don't want the anterior wall too far anterior to the window. So the size of the window is dependent upon how far you want to create the osteotomy for your implants. So if it's not going to go beyond the first molar, there's no reason to fill up the posterior wall. So you can limit this to the last tooth that you want to place your implant. Anteriorly, of course, we would go to the anterior wall. And the technique has pretty much stayed the same. You measure the height. So if you know the amount of height, we will probably be able to tell the volume of the sinus that we will have to fill with our grafts. So this is the membrane that's placed, graft, and then another membrane on the outside. A tack was used in the past. We don't use tacks anymore because we are able to contain the entire membrane predictably. This is the piezo's use, and this is the trumpet tip that will help us push the membrane, so you don't have to use the instrument for the elevation just to be able to detach the membrane from the window. Here's a patient who was very unhappy with his partial and is in need of full mouth reconstruction. Again, from a partial to a full prosthesis, how will we make that shift? Again, I use the same algorithm. We look at the age of the patient, we look at his profile, we study his occlusion, what kind of forces are being generated, the amount of wear he possesses, amount of smile line, the aesthetics, whether he has a molar to molar smile, and then we assess our skill levels too. If we don't do this at this point, at least we should find a specialist who can do it for us, because many of us don't do all the procedures in our office. So at least you should have the big picture before we plan the case. It doesn't have to all be in-house. You can always have a collaborative work to be able to reconstruct a patient. So if we look at the vertical dimension, I'm going to transition them into a full denture, and that forms the basis for our treatment planning. So we measure the aesthetics, phonetics, ridge relationship, arch form, smile line, and now we have a sinus that has been pneumatized. So this is the anterior border of the sinus. So we're pretty much at the mercy of bilateral sinus lifts, because if you look at it, the case is going to be an FP2. So if you do an all-on-X, you will need multi abutments. And if we are going to use multi abutments, that will increase the height of the prosthesis. So if this is going to be an FP2, we are able to provide enough augmentation to line up our implants to provide the patient with smaller segments of prosthesis. I'll explain the rationale. So after we are through with the lifts, you now have bone volume that is actually up to this point. So that's pretty good to be able to distribute our implants, right? So we're now going to be measuring the intaglio surface of the teeth of the denture to the incisal edge. That tells us the size of the prosthesis that we will be using, right? That will be required by the patient to have the aesthetics, because you're copying the denture aesthetics to the final. And in this case, no alveoloplasty is being performed. We are going to do ridge expansion. I use the denture as my guide. And again, these are all years ago, giving you a historical perspective of where we evolved and where we are today. Today, you could do this guided, but then you must have the skill to be able to expand through the guide as well. So we are doing some marks where the implant should go, and the implants are going to be distributed to provide for proper biomechanical support. And then the mandibular arch receives the same number of implants, and that helps us distribute the implants in such a way that we can segment a prosthesis into smaller units. So the final prosthesis will actually be indexed from the denture, so you can appreciate how many pieces there are in this reconstruction. I want to draw your attention to this exit point. This is a classic FP1 restoration. There is no platform to worry about. These are all cement retained. You can make them screw retained as well. But the narrower the occlusal table, sometimes a screw retained restoration could pose some challenges. Here are the occlusal schemes for the patient. Again, I want to emphasize the importance of an FP2, which provides us with an embrasure area. So FP1, FP2, in my opinion, is the gold standard in dental implants because it provides for natural form and function without any pink. So the advantage of these restorations, tomorrow if the patient chips one of the bridges, I can need to replace only this, or I can send it back for adapting the porcelain. So this would be a classic sequence, and we are now into our 12th year of function with this case. If there is about 5 millimeters, okay, there's 5 millimeters of bone, I should be able to do my lifts and implant placement. Now, does that mean I can do 3 separate lifts? Okay, because a lot of kits are available where they tell you you can do a crestal lifts with some of these crestal lift kits. Now, if we do those individual bumps, what's the guarantee that the entire membrane is going to be lifted up in one piece? There's no instrument that will go in and lift it uniformly. And if you create 3 separate bumps, the tension of the 3 separate bumps can increase the likelihood of tear in that membrane. So if you are placing 3 or more implants, it's very logical to do a lift, a lateral lift, and implant placement. So to give you an example of how this patient was brought to my office, they performed 3 crestal lifts, and this is how the patient landed up with an implant going into the sinus, which required a lateral approach Calver-Look surgery to retrieve the implant from the sinus. And then I had to go back in and do a lateral approach afterwards. So it takes about 4 to 5 months for the sinus to repair, the walls to repair. So this would be the reconstruction after that failure. And this is an FP3 type of restoration. So coming back to this case, we are evaluating the CBCT, and the instruments are now going to change a bit because you saw the time it takes for a rotary instrument with a number 10 round burr or with a piezo. Sometimes the walls are thick. If you look at the wall of the sinus, the lateral window, if it's thicker, we can use one of these rotary instruments, which is like an S-reamer, and then enlarge the entire window with these side cutting burrs. This allows us to place 3 implants at the same time. I'm placing the membrane as a shield to the crest. All right, and then the graft is then applied, and we shall place our implants simultaneously. So 4 to 5 millimeters of crestal height. You can do a lateral lift, place the implant at the same time. And these are the lateral lifts on the left side. I make 2 or 3 windows simultaneously with the stroppers, and then enlarge the entire window. There are other instruments available in the market. These are all like fluted cutting burrs. There are different names for different kits. You want to use something that is going to be predictable. There are also diamonds. The problem with the diamonds is that it gets clogged. It's very difficult to clean all the debris from the window of another patient before you use the next one. So number 10 round burr is a one patient use. We just make the window and throw it away. Whereas when these kits come with diamonds, while they are efficient, it probably should be used for a single patient. Right? That again, you need to be careful about how you can remove and clean the debris. So I'm using spacers, place the implant at the same time and with the graft and a PRF membrane over it. And this would be a quick video. It's considerably reduced my time in terms of my access. So we shall use the rotary. You can see the hue of the instrument on the lateral wall. And this is to enlarge. You can see the movement of the membrane as the patient breathes. These are the spacers to get the implants in place. All right. And then the graft. 3 implants inserted. Same thing on the upper left side. So typically it takes about an hour for the bilateral lifts, because within 20 minutes, you should be able to lift the membrane, place the graft. And with the implants also going to be used, you're looking at another 10 minutes or so. So it's improved our efficiency in being able to perform this very predictably. We're staying within the dentoalveolar region. We're not going extramaxillary. It's entirely within the sinus. So you can see as I'm drilling, I'm using the instrument to protect the membrane as I'm drilling. Right, and then we place the collagen membrane as a tent. And then the graft. This is sticky bone with the PRF. Implant placed after that. PRF membrane closure. In this case, we are going to be placing making the window and putting it back in. So this is the C-reamers that I used. If the window wall is quite thick, the rotary, it's going to take very long. The rotary diamond, it would have taken very long. So this is a trephine type of burr. The wall is about 4 to 5 millimeters thick. That's another reason why a CBCT is imperative. We lift this. This is the Kirkson puncher forceps to be able to open up any of the undercuts that are there. A lineup of the PRF. Osteotomy prepared. You can see I'm using the instrument to protect the membrane. And then after the osteotomy is prepared, we will then place the graft. Okay, this is the technique that we recommend. So this will have a memory, as you can see, it doesn't slump. So you're able to hold this. And as you insert it, it will open up like an umbrella. So that's good, as opposed to a membrane which has no memory built in. So after the augmentation, the implant goes in. Okay, so then we take the bone that we just removed and place it right back. It doesn't have to be secure. You can just place this. It's almost like a green stick fracture. Place the membrane right over. And then we get the closure. So we can expand the possibilities to completely atrophic ridges too. So here, we are at a standstill. What do we do in a completely pneumatized sinus? So here's the video for this. I'm going to show you the cross section of the scan. So this is pretty much what we have left with. Less than a millimeter in some areas, and it's through and through all the way across. From the posterior maxilla to the medial wall, it's completely atrophic. So one of the big risks in elevating this membrane is the possibility of tears. So we need to use instruments that are going to carefully dissect and open up the site. So in the premaxilla, there's hardly any bone because of the combination syndrome. So we draw blood, open up the site, we're making the window, and then I'll place a membrane to keep it up. You want to make sure that that is going to be there in the event of any tear, because you're not always sure, because the membrane will stop moving after we reflect it from all the sides. And it's very hard to tell if there's a perf, but pretend every membrane may have a perf, and be very careful about handling the grafts, because the last thing you want is for the graft to enter into the sinus. So this is a way of handling the spread. We're using sticky bone, which will not move around. So the platelet-rich fibrin will help us contain the graft, and you will have a good fill. How much to fill? Till you get resistance to packing. So you don't want to overpack. It's not an amalgam condenser. You don't need to pack it so much that it's going to be difficult to put any more grafts. So you should have passive resistance. And then the same thing on the opposite side. We make the window, and then we can touch it up with a piezo. And you see the confirmation of the intactness is to be able to see the membrane breathe as the patient inhales and exhales. And this, of course, is not a case where you would be placing the implant at the same time. So we do this as two separate procedures. Again, you can see the fill. And this is the post-op after the fill. We wait typically about 5 months before we can go back and place the implants in. So here's the fill that you can notice. It's well contained. And then I'm going to do a ridge expansion to be able to place the remaining implants. I could go on and on, but I think we are getting close to the conclusion of the webinar. Nicole, are we good with time?
We are.
Okay. So maybe we can open up the floor for some discussion if there's time.
Absolutely.
Thank you, Shankar. Thank you. Yeah, we do have quite a few questions. Let me jump to them. I wanted to ask you. A lot of times you hear about people doing sinus grafts through an apical approach of the osteotomy.
Yeah.
When is that appropriate versus using this lateral approach?
Well, I showed you in the case where the sinus has pneumatized completely, it's almost difficult to do a crestal approach. So the crestal approach, my recommendation would be have minimum of 5 to 6 millimeters of alveolar height before you can do a crestal approach for a single tooth. Now, if you have multiple osteotomies, I generally go lateral, even if there is 5 millimeters.
Got it. Got it. Okay. And you mentioned early on that you used for your graft material, you used a mixture of xenograft and allograft. Do you still do that, or what is your current graft material that you're using?
Good question. So, my current practice has minimized the use of alloplasts and xenografts. So maybe at the most, I would use about 20% of a xenograft, mainly so that I can see it on a radiograph properly, but otherwise it's exclusively allografts.
Got it. Got it. You mentioned also using a membrane with memory.
Right.
What membranes are we talking about? What materials?
Well, you know that membrane which is cross-linked with glutaraldehyde or with
Right.
acetone. When you wet it, it doesn't slump. It maintains the memory. So that's the typical kind of type 2 collagen cross-linked membrane is what we want to use, not
Cross-linked.
something.
Got it.
Yeah,
Yeah. I
cross-linked.
think most of the collagen membranes now are cross-linked, are they not?
Not collar tape and collar plug. These are not cross-linked. So
Okay.
that's not a membrane. That's just a tape. It's poorly configured.
Right. Right. Yeah. The Newport Biologics, the 2.3, the 3.4, they are cross-linked. So I think that's
Cross-linked.
the memory you're talking about. What about placing implants at the same time as sinus augmentation? How do you get yourself to be sure that you have primary stability, or is this not a recommended procedure at all?
Great question. Great question. Because it all has to depend upon the amount of alveolar crest height, the design of the implant. You don't want to use a crestally tapered implant for these kinds of immediate placements. You also don't want to use a platform switched implants for these cases because the platform switched implants require implants to be submerged 2 millimeters below the crest. If you only have 5 millimeters, and if you want to lose that 2 millimeters, then the amount of primary fixation is going to be diminished. So if you're doing it at the same time, you really have to think through this with an algorithm. Do I have good density of bone? Could I have good volume of bone? Do I have good width of bone? What's the configuration of the implant? Do I need an aggressive thread or a subtle thread? Do I use a crestally divergent type of implant or a crestally tapered implant? Parallel wall versus tapered. A tapered definitely is preferred in many cases.
Right. Right. Excellent. Okay. And what about you showed some really nice instrumentation, reamers and curettes. Is there a particular brand you can recommend for looking at those
Yeah,
instruments?
because it's now almost generic. You can get them from most companies. They're called as S reamers or C reamers. We don't particularly subscribe to a brand as such. You want to make sure that it doesn't cut the membrane, so you need to inspect the flutes and how these designs are created with different diameters and also with drill stops, so that you don't go too deep into the sinus.
Very good. Very good. Um, I've got a question about this hydraulic technique
Yeah.
for raising the floor. Is that something that you are recommending?
Yeah, hydraulic technique is good for membranes that have some kind of consistency. It's better than blindly taking a drill and starting to lift. So the hydraulic lift, I didn't have time to show this to you, is usually good when you can see the membrane and the floor is within 5 millimeters from the crest. And the resistance is there for you to actually push some saline and get a nice lift. Maybe that'll be the topic for our next webinar to do a crestal lift with different types of instrumentation.
Great, great. And I've got a question. One final question here. If you're doing an extraction and have a sinus perforation at that time, what is the best technique? Let's assume it's less than a 5 millimeter perforation. Is that something you can put a collagen plug, and then do you need to have primary closure?
Good question. So it depends upon the amount of alveolar height of the extraction socket. After extraction, if the oroantral fistula is in line with the palate, then you have to use a buccal fat pad. Otherwise, if you still just have a socket with parallel walls present, then I would use a long-standing resorbable collagen membrane like a tent, and then put a collar plug and no graft.
Great,
That would
great.
be a good way to seal it off.
So I was texting with Dr. Hochberg during your lecture, and we have agreed that you are a fine gentleman. You've been a good friend over the years, and we always enjoy our association with you and working with you. Looking forward to seeing you. Go ahead, Dr. Hochberg.
No, I just wanted to
Hi,
say it was
David.
great. He always is great. I can't wait to
Always.
see you in Atlanta.
Me too, me too. And thank you for being there always, leading the education committee. So honored and proud to work with you for years. And
Oh,
thank you.
great. So, Dr. Shankar Iyer,
you.
thank you for a fantastic presentation today. We learned a lot, beautiful videos, beautiful documentation. We all enjoyed it. And we're going to be off next week for the IOX Symposium. So join us on October 25th when we will have Dr. Danielle Brown, and she's going to be talking about aesthetic veneer preparations from the full prep to the no prep. A lot of people want to do no prep veneer. She's going to tell you when you can do it and how you can do it. So thanks to the panel. And we'll see you back in 2 weeks. And we're looking forward to it. Everybody have a great couple of weeks.
Absolutely.
Take care. Bye-bye.
Bye-bye.
Thank you so much.